Hello.
Hello.
Hello, good evening, sir.
Good evening. Hello, shall we start the program? Hello.
Hello, Dr. Saroj there?
Yes, sir. Yes, madam. I'm here, madam.
Okay, now you share your screen, ma'am.
Madam, little bit. I am first time doing it. I don't know much.
Okay. You can open your PowerPoint in first. You can open your PowerPoint.
How will I go? I have to.
You have joined from a laptop, na?
Yeah, laptop. Right. PowerPoint. Yes, I.
Okay.
1 minute, madam.
Now come on Zoom screen.
Yeah.
There is option for green button, share screen button. Click on that. Bottom side, middle, green button, share screen. You can click on that, ma'am.
Madam, launch is coming. I don't know.
No, ma'am. You have to click on green button, share screen. Open your Zoom screen.
Open my Zoom screen. Yes.
Yes. जहाँ पे आपको सभी का लॉगिन दिख रहा है, सभी का नेम दिख रहा है, right?
Yeah, madam.
Okay. Now click on green button, share screen button.
Green, right?
Yes, green button, share screen. Click on that.
Yeah. Is it? Can you see my screen?
Yes, ma'am. It's loading. Okay. Now you can do full screen mode, ma'am. You can do slideshow from beginning.
Full screen. How to
bottom side there is one button, 3 button, na? Beside that, third one. Go right side, right. Go right side, ma'am. Slideshow. Yes, click on slideshow. No, ma'am. Left. Yes, click on that button, slideshow. Okay, click on that. Now you can change the slide from the keyboard, left and right arrow key.
Yeah, that is okay. Yes. Sir, good evening, sir.
Okay, good evening, Saroj. You are ready for the presentation?
Sir, I don't have echo plate.
That's
Sir,
not matter.
Recording.
That's not matter. No problems. We will ask one of the participants to discuss also. Is Egnath available there, Egnath?
Sir, there may be many mistakes, sir. Please excuse me. Sir, I am presenting first time, sir.
No, don't worry. Everybody makes mistake when they start doing it, and then gradually you can become an expert. Nobody is an expert when they are born. You gain expertise by doing repeatedly. Don't worry about it. Anybody who would like to discuss the case? Ranjan? Hafeesh, would you like to discuss? Egnath? One of you should come forward to discuss. Then only we can have an effective discussion. There is no point in the story discussion by the presenter. Abhi, are you there? Any volunteers to Shashikant? Hafeesh, are you there, Hafeesh? So what shall we do? Nobody is willing to discuss the case. I am surprised that none of you is volunteering to discuss the case, because by repeated discussion you become very confident, and in the examination it becomes easy for you to take forward the discussion. Anybody who would like to discuss the case? Any volunteers? Okay, Saroj, then we'll start the discussion, and then we'll see how we can take it forward. Okay. Okay, Saroj, present the case.
Okay, sir. Sir, patient's name, Mrs. Sarojini, 53-year-old female admitted to our hospital with complaint of shortness of breath for last 10 years. She was on regular follow-up as OPD basis. Palpitation off and on for last 10 years. Mild bluish discoloration of the body for last 5 to 6 years. So, history starts at the age of 6 months when her parents noticed increased breathlessness and tachypnea while feeding the baby with increased precordial activity. She went to doctor and to the hospital, sir, at the Andhra hospital, and she was investigated and she was told that she has got some heart disease, but now no medicine is needed or no intervention is needed. And she was asked to come for follow-up every 2 years. During her childhood, she felt fatigue very easily while playing with her peer group. And in the beginning, the symptoms were with exertion, and later on, they also started to have with no, sir. During childhood, sir, I cannot see the full screen. During her childhood, she felt fatigue easily while playing with her peer group. No history of recurrent LRTI or suck rest cycle during the infancy. During that period, she also felt palpitation off and on while playing, but never at rest. The palpitations were regular in nature and associated with shortness of breath and extreme fatigability and sweating. She had failure to type and she was underweight than her younger sister. There is no history of cyanosis in her childhood and there is no history of squatting episodes. Sir, this during her childhood, sir, I just narrate the history that the parents noticed that she was symptomatic and tachypnic at the age of 6 months. But there was no history of suck cycle and no history of cyanotic spell. But it was associated with mild breathlessness and palpitation.
Now you complete the story, then we can go to the discussion.
Now, sir, she was apparently asymptomatic till her 18 years of age, and she got married and she delivered 2 children by the age of 24 years, and she had to be hospitalized during that period for before the delivery of the second baby. She had a shortness of breath as well as generalized swelling and palpitation. The palpitation were regular in nature and with spontaneous recovery from the palpitation. She was she was relatively asymptomatic till her 40 years of age, except few episodes of self-limiting regular palpitation off and on during this period from 24 years to 40 years. Palpitation which were regular at first, but now, sir, they are irregular in nature, gradual in onset and offset, increases with exertion and brisk walking, and now she feels palpitation even at rest, and there is no history of post-palpitation diuresis.
Did you want to ask that story post-palpitation diuresis?
Sir, I wanted to exclude whether the palpitation were supraventricular type or not.
Why do the patients with supraventricular tachycardia develop diuresis?
Sir, because, sir, in case of supraventricular tachycardia, the atrium is at stretch. As a result, it secretes atrial natriuretic peptide, which causes the diuresis.
Why the atrium is stretched? What is the mechanism?
Sir, because of the tachycardia, the left atrial pressure will, the left atrial dilatation,
No. The patient is having a supraventricular tachycardia, and it mostly occurs in people who are healthy. and at that time there is no atrial dilatation. And why should there be an atrial stretch or atrial pressure rise during the time of supraventricular tachycardia? That is the question.
So natriuretic peptide is of two types. One is atrial, another is a brain natriuretic peptide.
No. I'm not asking you why should the. First of all, you said that the rise in the atrial pressure results in release of natriuretic peptide.
Sir, I forget.
Okay, anybody who is available here, would you like to tell me the reason why in a patient with supraventricular tachycardia there can be diuresis? I agree with you that there can be diuresis in a patient with supraventricular tachycardia. I would like to know what is the mechanism. I also agree with you that the rise in the atrial pressure is the reason for release of atrial natriuretic peptide.
Stretch receptors in the left atria. The left atrial stretch receptors.
Well, that is right, but why should it be? Why should the stretch receptors be stimulated? Any participant, would you like to answer that question? Manjunath, would you like to answer that question? Manjunath?
Sir, I think like it might be the atrial rate is more than the normal atrial rate. So it causes more, not actual contraction, but the flickering movements of the atrium. This might be a reason.
No, that's not the reason. Any other person, would you like to try? See, do you see a Cannon wave in a patient with supraventricular tachycardia? Do you know what is meant by frog sign?
We get in SVT, sir.
SVT.
Supraventricular tachycardia.
Yeah. What is the reason? That is because the atrium and the ventricle contraction occurs together, resulting in regular Cannon waves in the neck. And whenever there is a simultaneous contraction of the atria and the ventricle, what will happen to the atrial pressure? Because atrium is not able to empty its contents to the ventricle, that will result in acute rise in the atrial pressure because of the atrial contraction, and that stimulates the atrial natriuretic peptide release. I will repeat, in a patient with supraventricular tachycardia, there is simultaneous contraction of the atrium and the ventricle, which will result in atrium contracting over a closed atrioventricular valve, and there is an sudden acute rise of atrial pressure when the atrium is contracting. This will result in release of atrial natriuretic peptide, which causes diuresis. So, supraventricular tachycardia, AVNRT as well as AVRT, both can give rise to simultaneous contraction of the atrium and the ventricle, and this can more so in AVNRT, where definitely it is simultaneous, and that can result in atrial stretch, atrial pressure rise, and that can result in atrial diuresis. Okay, so that is the reason. Okay, right. Go ahead, Saroj.
So at the age of 40 years, she started having gradually worsening of shortness of breath, insidious in onset, gradually progressive, aggravated by exertion, and relieved after rest. At first, she used to be breathless after 2 flights of stairs, about 1 kilometer, and then it progressed to NIHA 3 during 4 to 5 years, and was able to walk only 100 meters, and was not able to climb even 4 to 5 steps. And about 1 week back, she was admitted in our ICU in a with severe respiratory distress in NIHA class 4, and she was orthopnic at that time, and she was unable to walk even few steps and was bedridden. During last 4 years, this symptom, she is admitted 3 times in our hospital. There is no history of PND or worsening of symptoms during sleep. Her breathlessness was not associated with any specific posture or expectoration. Her breathlessness was associated with fatigue, which also worsened from NIHA 2 to NIHA 3 during last 10 years. She also noticed mild bluish discoloration of the body, which increases on exertion and decreases after taking rest mildly, but does not disappear during last 5 to 6 years. But now the cyanosis is persistent and remain even after rest.
Okay. Next slide.
Yes, sir. Sir, there is history of pedal edema, both legs, for few months with mild abdominal distension and facial puffiness and right hypochondrial pain, which relieve after medication. The history of present illness is
I will complete the story, then we'll go to discussion.
There is no history of hypertension, pulmonary cough, or COPD, no history of rheumatic fever or monthly injection in the past, no history of giddiness, syncope, convulsion, or loss of consciousness, no history of prolonged fever, skin rash, sore throat, or fleeting joint pain, no history of dysphagia, hoarseness of voice, or hemoptysis. The treatment history.
No, all right, okay.
The patient consulted doctor at the age of 6 months, 7 years, 24 years, and after the 40 years, regularly to our hospital. At the age of 6 months, she was asked for the 2-yearly follow-up, but she did not compliant with that. And during her pregnancy and the delivery, she was under strict observation for the swelling of body and shortness of breath and palpitation. Since her 40 years of age, she is on regular checkup and she is having blood thinner, diuretic and digoxin tablets. She has to have an INR every month after the 40 for last 5 to 7 years, and she has intermittent epistaxis in spite of her regular INR checkup. Birth and developmental history. She is second sibling among the 5 children. She was born of non-consanguineous marriage, full-term normal delivery. She herself has 2 children. Younger son died due to some heart disease at the age of 23 years. Physical underdevelopment noted by the parents in the form of poor weight gain. There is no psychological or educational or developmental delay was noted, and there is no history of similar heart disease in her own family other than her son. Personal and family history. She takes mixed diets and she belongs to a low middle socio-economic status. Bladder, bowel, sleep, appetite normal, and there is no habit. No history of lithium intake, anti-epileptic drugs, or anti-thyroid, or smoking or alcohol by the mother during pregnancy. So,
okay, no. Now we have to discuss the story. Any volunteers to discuss the story before? Otherwise, we have to ask Saroj to discuss. It is better that somebody else discusses. Any volunteers? Any volunteers? Ranjan, would you like to discuss? Ranjan, are you from GH Kochi? Manjunath, would you like to discuss? Manjunath, would you like to discuss the story?
Yes, sir.
Okay.
Actually, the main comes with it is from the birth till the age of 53, sir.
Okay.
The
Now you do step by step. First question is it a cardiovascular system disease?
Yes, sir, cardiovascular system.
Why?
Because history of breathlessness with palpitation, sir, and blues discoloration.
Yeah, blues. So you think that, and also from the early childhood, somebody has diagnosed that she has got a heart disease, because
Yes,
when she was at the 6 months of age, when she was taken to a doctor, he said she has got a heart disease. So it's a cardiovascular system disease. Do you think that this is a left-sided disease or a right-sided disease?
Left-sided disease, sir.
Left-sided disease. Why do you think it's left-sided disease?
Breathlessness, initial complaints, sir, with the childhood history from 6 months of breathlessness to tachypnea.
No. So breathlessness is for the past 10 years. She was taken to the hospital for not breathlessness. What was the symptom for which she was taken to the hospital? Slight tachypnea is there, but she had increased precordial activity.
Hypertension.
So what does that mean? Is it a what type of a pathophysiology is there?
Not able to get, sir.
Well, see, if you look at a heart lesion, you have to think of the pathophysiology, which includes volume overload, pressure overload, primary myocardial disease, restrictive illness. So if you or arrhythmia, if you consider all these points, what do you think would be the pathophysiology in this patient?
Volume overload, sir.
Volume overload, very good. It's a volume overload because her main symptom is palpitation. Even from increased precordial activity was noticed by the parents, and so it is a volume overload. Is it a volume overload? What is the commonest volume overload in a child 6 months of age?
VSD, PDS, sir.
Yeah,
Mainly.
you think of a shunt lesion, because volume overload can be classified into two: a shunt lesion and a regurgitant lesion. Of the two, you will think more likely to be shunt lesion. From the story, you think this is a pre-tricuspid shunt or a post-tricuspid shunt?
Post, sir. Post.
Oh, sir. Why do you think it's a post-tricuspid shunt?
It might
Why
be
do you think
pre.
it's a post-tricuspid shunt? You have to tell me the reason. What are the post-tricuspid shunts?
VSD, sir.
VSD,
PDA.
PDA, and AP window. These are the three post-tricuspid shunts. So you think it's a post-tricuspid shunt. Reason? And what is a pre-tricuspid shunt?
ASD.
ASD. Okay. Okay. So here, why do you think it's a post-tricuspid shunt? How do you diagnose post-tricuspid shunt?
So can we say PAPVC also pre-tricuspid?
Yes, PTAPVC also can be taken as a pre-tricuspid, because I didn't bring that in because at birth the child was not cynosed. So it is not a cyanotic congenital heart disease to start with. Otherwise, you can also include partial anomalous pulmonary venous drainage as well as total anomalous pulmonary venous drainage. Both also can be included as part of the volume overload pre-tricuspid shunt.
I said for my query, sir, whether pulmonary AV fistula will be also taken.
Pulmonary fistula is not you cannot be taken as a volume overload condition. Agree with you that there is it's not a shunt lesion. It's actually something like a situation where blood flowing through the AV defect, pulmonary AV defect. What did you say? AV canal defect.
No, sir. Pulmonary AV fistula.
AV fistula. AV fistulas can give rise to slightly increased volume coming to the left ventricle, but that is not a shunt lesion.
Yes,
So I will not put it as a shunt lesion. So the volume increase in the volume is also very minimal, not comparable to a shunt lesion. So Manjunath, how will you diagnose whether it's a pre-tricuspid shunt or a post-tricuspid shunt?
Sir, if it is a tricuspid shunt, the breathlessness, the event of breathlessness will be much late than the post-tricuspid shunt, sir.
Okay.
And in VSD, we have a large amount of blood shifting from left to right. So there is a precordial activity more increase and breathlessness chance. If you compare with the pre-tricuspid shunt, post-tricuspid shunt, in this history, I could like to give.
Okay. In post-tricuspid shunt and pre-tricuspid, in post-tricuspid shunt, which ventricle is in trouble? Is it the right ventricle or the left ventricle?
Sorry, sir, didn't get you, sir.
In a post-tricuspid shunt, which ventricle is in trouble? Is it the left ventricle or the right ventricle?
Right, sir.
In a
left ventricle.
left ventricle. It is a left ventricle. So in a post-tricuspid shunt, you should have features of left ventricular failure, like the she has definitely said no history of recurrent respiratory tract lower respiratory tract infection, no suck cycle during infancy. All these points are against a post-tricuspid shunt. From the story, the features are more in favor of
pre-tricuspid.
And because there is no, from the story, there is no history to suggest that the left ventricle was in trouble. Like features of left ventricular failure, or the patient is having no recurrent lower respiratory tract infection. All those things are more in favor of a pre-tricuspid shunt. If you look at this natural history that has happened in this lady, do you think that this is a pre-tricuspid shunt or a post-tricuspid shunt?
Pre, sir.
Why?
Most probably ASD, sir.
Why do you say
Because
that?
the natural history of VSD and VSD, sir, it is the presentation and the duration of if you compare ASD with VSD, natural history, patient I forgot the percentage, sir. But
what do you see when there is a large PDA or large VSD? What is the natural history? What complication do they develop?
Early pulmonary hypertension.
Early pulmonary arterial hypertension. These patients can go in for progressive elevation of pulmonary vascular resistance, pulmonary arterial hypertension, and they present with Eisenmenger syndrome. At what age?
Sir, in case of VSD, it is second decade, and PDA may present in first decade.
Both are roughly first decade. You take it AV canal defect, AP window, and early second decade you can go for PDA, and late second decade you can go for ventricular septal defect. So this patient did not have any problem during the, and when you look at the history of these patients, how do these patients with VSD PDA present? They usually will have early symptoms, and after 2 to 3 years of symptoms, their symptoms gradually come down. And what are the mechanisms of symptoms coming down in a VSD?
Sir, there may be 3-4 mechanisms. First, there may be spontaneous closure of the VSD itself.
The reduction in size or spontaneous closure of the VSD. Very good. Yes.
Second, sir, the VSD may be Gasul's phenomenon. There is a RVOT, hypertrophy, and sir, there may be a contraction, and then sir, there may be left to right shunt decreases then.
Very good. There can be a RV outflow obstruction, hypertrophy, Gasul VSD, and that can result in less of right to left shunt. Patient becomes less symptomatic. Third,
sir, sometimes because of some tricuspid valve per se can block the VSD, and sir, the VSD may be decreased.
Yeah, there are many mechanisms by means of which VSD can decrease in size, and one of the mechanisms, or one of the more important mechanisms, is septal leaflet of the tricuspid valve can get attached to the VSD and then reduce the size of the VSD. Okay, right? Yes.
Sometimes the right coronary cusp for the aortic valve may get prolapsed due to the Venturi effect, and then sir, it may be the VSD size may be decreased.
But then what they develop another complication?
Aortic regurgitation.
Yeah. So there can be a temporary reduction in the VSD, but then as a trade-in complication, they develop aortic regurgitation, and if it is significant aortic regurgitation, they can become symptomatic.
Yes,
you can also mention patients can develop pulmonary arterial hypertension. Initially, they become less symptomatic, shunt becomes less, until the time they develop Eisenmenger syndrome, when they can become again symptomatic. So in a patient with VSD, there are 3 important mechanisms by which the VSD can become less symptomatic. One, as you rightly said, either closure of the VSD or decrease in size of the VSD, effective size of the VSD, due to many mechanisms. 2, development of RV outflow obstruction. 3, development of pulmonary arterial hypertension, Eisenmenger, not before Eisenmenger reaction, during which period the left right shunt becomes less, and the overloading of the ventricle also comes down. So, and in a patient with prolapse of the aortic cusp into the ventricular septal defect, even though the VSD becomes smaller, these patients can have actually aortic regurgitation, and depending upon the severity of aortic regurgitation, they can actually become symptomatic. Okay, so in this patient, if you look at the natural history, what has really happened? Saroj, do you comment about the natural history of this patient, which will help you to come to a diagnosis?
Yes, sir. It is a very slowly progressing disease.
Okay.
And sir, there may be, sir, bimodal presentation type. Like once the patient was symptomatic in the first decade, and sir, the disease is making worsen during pregnancy and delivery, and again reappearance in the fourth decade.
But she did not deteriorate during delivery, but she was told that she has to have a hospital delivery, and she had a normal delivery.
Yes, sir. Yes, sir.
So she tolerated the delivery reasonably well. Now, what is the natural history of ASD?
The natural history of ASD is like usually, sir, in the fourth decade, the patient develops more symptoms and atrial fibrillation.
Okay, they can develop atrial fibrillation, and then they can become more symptomatic. Why do they become more symptomatic?
Because the left to right shunt increases because of the development of the atherosclerotic process or the hypertension, or the left ventricular end diastolic pressure for any reason increases, then sir, left to right shunt increases.
Okay, don't say about atherosclerosis, hypertension and all, because in a 40-year-old lady, are you expecting atherosclerotic changes?
No, sir.
So don't tell all those things. You should say that the left to right shunt in a patient with ASD is decided by the relative compliance of the left ventricle and the right ventricle. Normally the right ventricular compliance is much more than that of the left ventricle, and hence there is a left to right shunt. As the age advances, the compliance of the left ventricle further falls, resulting in at the same time the compliance of the right ventricle practically remains the same. And because of the reduced compliance of the left ventricle, the left to right shunt across the ASD actually goes on increasing, resulting in more and more left ventricle shunt from left to right through the atrial septal defect. And the increase in shunt gives rise to two problems. One, the RA dilates, resulting in
atrial
fibrillation. And second, the progressive dilatation of the RV, and that can result in two complications. One
RV failure.
RV failure. Two,
and development of pulmonary artery hypertension.
That is late. When there's a shunt, they can develop dilatation of the tricuspid annulus, and they can give rise to tricuspid regurgitation.
Yes.
So the tricuspid regurgitation also can contribute to right atrial enlargement, atrial fibrillation. And these patients with ASD can present with heart failure in the fourth or fifth decade, especially when they have developed atrial fibrillation. Heart failure may be precipitated by atrial fibrillation. So two complications that can happen, which can result in symptoms in these patients with ASD, are one, development of atrial fibrillation, and two, the increase in the shunt result in heart failure. So both the symptoms this patient has. Manjunath, is this patient in heart failure?
Yes, sir, definitely, sir.
Why?
Because of NY, first of all, pedal edema.
Yeah, this patient has got pedal edema, and she has got breathlessness. So all those things. Orthopnea. All those things indicate that she has got she's in heart failure. When you're suspecting atrial septal defect, we said it is the right ventricle is in trouble. So can patients with right RV failure develop breathlessness? Saroj?
Yes, sir. RV failure patient can develop breathlessness.
What are the mechanisms?
Sir, one mechanism is that, sir, though RV blood supply is not hampered, because the RV is thin and it gets its blood supply sometimes from the RV cavity per se. But still, the patient can have breathlessness because, sir, because of the forward flow from the RV during the RV failure decreases. As a result, sir, venous return to the left side of the heart also decreases, and then sir, cardiac output decreases and may cause shortness of breath.
What is the symptom of decreased cardiac output? Is it shortness of breath?
No, sir, fatigue.
Fatigue. So, so why should they have shortness of breath?
And
Sir,
sir, sometimes
Yeah.
dilatation of the pulmonary artery
Uh,
can compress the coronaries.
no, not coronaries.
interventricular septum bulges towards the left ventricle, sir, because of the RV dilatation.
Okay, there's a reverse Burnham effect which can encroach upon the on the LV cavity and can result in the elevation of the LV and diastolic pressure, and that can give rise to some symptom of breathlessness. Another mechanism,
Sir, hypoxia can also,
hypoxia, what due to what?
sir, hypoxia
Pulmonary
because
arterial hypertension causes deoxygenated blood, sir. As the progress of the disease, it causes pulmonary hypertension. 14% of ASD can go for pulmonary hypertension. So,
But most of the patients of ASD, they never go for pulmonary artery hypertension. Almost 80 to 85% of patients actually present with atrial fibrillation and heart failure, but they can have a breathlessness as an important symptom.
Turger effect, sir.
Turger effect, yes. What is Turger effect?
Sir, it is myocardial edema. It occurs due to coronary sinus congestion due to right heart failure.
Okay, very good. When the coronary sinus drains into right atrium, and when there's right heart failure, the coronary sinus venous pressure, which is the venous drainage of the heart, increases, resulting in myocardial edema, and the myocardium becomes less compliant. That can result in breathlessness. Very good. What else?
Sir, heart muscle act as a syncytium, sir.
Okay, very good. So
if one chamber fails, then it subsequently leads to left other chamber failure, sir.
very good. If the heart is a syncytium, and when there is a strain on the one chamber, there may not be equal strain, but there can be some degree of strain on the other ventricle also, and there can be an elevation of the some degree of RV dysfunction also can happen. RV chamber can become smaller in size, and there can be some strain on the the LV chamber can become smaller in size, strain on the left ventricle, and that can result in some degree of LV dysfunction. Yes, what else? These patients, sometimes there is something known as when there is a low cardiac output, as Saroj was trying to explain, that can result in a reduced blood supply to the respiratory muscles. And because of the reduced blood supply to the respiratory muscles, they fatigue easily because of the hypoxemia, because of the reduced blood supply, and that can result in a symptom of breathlessness. And another mechanism postulated is that there are something known as J receptors in the hilum of the lung, and when there is a pulmonary arterial hypertension or dilatation of the pulmonary artery, these receptors can get stimulated, and that can give rise to symptom of breathlessness. And these patients with the right heart failure can develop pleural effusion. Sometimes they can have pericardial effusion, and all these can also contribute to development of breathlessness. But these patients will never have paroxysmal nocturnal dyspnea. They can even have orthopnea, but not paroxysmal nocturnal dyspnea. So this patient has got orthopnea, but there is no history of paroxysmal nocturnal dyspnea. So the symptoms can be explained by atrial septal defect itself. Okay, right? Yes. So is there any other point for us to suspect that this could be atrial septal defect? Anything to do with the history of pregnancy and delivery? Subhasis, do you like to comment?
Sir, ASD is better tolerated in pregnancy, sir.
Very good. ASD is well tolerated in pregnancy because the left ventricle is not at strain, and so the pregnancy can be well tolerated, and the toleration of the pregnancy in a patient with who is symptomatic from early childhood also points towards the lesion being atrial septal defect. Okay. Okay, right. So we have got plenty of points to suspect that this could be an atrial septal defect, like the early detection of a volume overload condition from the symptoms. Left ventricle is spared. The patient continued to live and got married, led a normal sexual life, became pregnant, and had normal 2 deliveries. And patient has developed atrial fibrillation, and the patient now is presenting with heart failure at the age of 53 years, in the 6th decade. all these plans. There is some degree of minor cyanosis also, so that may add that probably the patient may be having some degree of pulmonary arterial hypertension, and maybe there may be some bidirectional shunt. No, it cannot be a complete right to left shunt, but it can be something like a bidirectional shunt. So the patient still having a left to right shunt, dominant left to right shunt, a possibility of some degree of right to left shunt also, a bidirectional shunt also is likely because of the story of cyanosis. Do you think this is a total anonymous pulmonary venous drainage? Subhasis, Manjunath?
No, sir, because
Oh,
PVC has got a very stormy course.
okay.
Sir, during newborn or sir, first week only they present with a failure.
That depends on the if the total anomalous pulmonary venous drainage where there is an obstructive element like infradiaphragmatic TAPVC, they come symptomatic on the first day of life itself, and unless they are operated, they die. But some of the patients with supracardiac TAPVC with a balanced obstruction, sometimes they may be able to live longer, but not up to the age of 60. I agree with you that sometimes they may live 12, 15 years of age, and then they are detected and they get operated. But the life expectancy to the 6th decade, 53 years, is very unlikely for a total anomalous pulmonary venous drainage. Do you think that this can be partial anomalous pulmonary venous drainage with intact interventricular septum?
Yes, sir.
Yes. Why do you think it is yes?
Because I had seen one patient, sir, sinus venosus with the partial anomalous PAVC. It was around 55 years age. We referred it for surgery. Now she's fine. But the natural course.
No, then the patient is having patients with sinus venosus type of ASD very often have one of the pulmonary veins. Which pulmonary vein is anomalously draining?
Sir, right upper.
Yeah, right superior pulmonary vein can drain anomalously into the through the defect into the right atrium. That is quite possible, and the surgeon should know about that so that when he does the patch closure of the ASD, the pulmonary vein can be directed towards the left atrium.
So because sir, here the problem is with the septum spurium. So this is a part of sinus venosus which is being engulfed into the right horn.
Very
That's
good.
why septum spurium and problematic. Then sir, we get the sinus venosus ASD with right superior pulmonary vein anomalously drained.
Okay. The importance of recognizing this is to tell the surgeon that right pulmonary vein is draining anomalously into the right atrium, because when he does the closure of the sinus venosus defect, he has to redirect the closure should be done such that he has to redirect the right superior pulmonary vein into the left atrium. That's very important. Otherwise, the patient will continue to have a left to right shunt. See, in a patient with partial anomalous pulmonary venous drainage or in a natural history, what happens to the whatever it is the reason shunt? Does it increase or remain the same? What happens?
So it will remain same.
It remains the same. There will not be further increase, and many times partial anomalous pulmonary venous drainage is well tolerated. It does not increase. The patient does not develop atrial fibrillation. No problems. So it is in ASD that there can be a progressive increase in the left to right shunt. Patient can develop atrial fibrillation, and these patients can go for heart failure. Okay, right. Yes. So any other differential diagnosis? What would you like to consider?
Sir, can Epstein's be a differential, sir?
Which one?
Epstein's anomaly, sir.
Epstein's anomaly, yes. Can the Epstein's anomaly be a differential diagnosis? Saroj, would you like to discuss that point?
Sir, I will discuss this later on.
Okay.
I know
Anybody who would like to discuss whether this could be an Epstein's anomaly? Whether this could be an Epstein's anomaly? What are the points in favor of Epstein's anomaly? What are the points against Epstein's anomaly?
The against is the age, because it's a bimodal presentation, so most of the time it will present in 4th decade.
Yeah,
Yeah,
okay.
third to fourth.
And that depends upon the RV function and displacement. So they can present in the fourth or fifth decade, or sometimes they can be asymptomatic even the sixth decade, no problems. So Epstein's anomaly can be definitely discussed, and what are the points in favor of Epstein's anomaly? What are the points against the Epstein's anomaly? Points in favor? Ronak, would you like to? Oh, you were not there when the history was presented. So
Yes, sir. I just joined, sir.
okay. So do you think that this could be Epstein's anomaly? Anybody?
In favor of Epstein anomaly, palpitation is present.
Yes. Palpitation and development of atrial fibrillation. Two
Yes,
important points instead of yes. What else? Life expectancy up to this age is possible. Third,
Sir,
yes, yes.
sir, it's a life expectancy is up to fourth or fifth decade is there, but above there it's a rare phenomenon. Means it could not be beyond 50 years of age.
No. I have got two patients who are 78 and 80, who have been under my follow-up for the past from 1977 onwards, maybe about 40 years.
Mm.
And sir, also in favor that no history of PND, sir. Though the patient develops sir, edema.
Now, PND both for ASD as well as Epstein's anomaly, that is quite fine. No features suggestive of left heart failure. So here the features in favor of, or rather why we should consider are: one is the patient has lived up to this age, that is possible. Two, left-sided, right-sided disease, no left-sided problem. Three, patient has developed atrial fibrillation, and the patient has developed cyanosis, mild cyanosis. What can be the mechanism of cyanosis in a patient with Epstein's anomaly?
Sir, cyanosis in Epstein anomaly is also bimodal. First,
Yes.
in the newborn, because
Okay.
of the primary pulmonary arterial hypertension. Sir,
No, not primary pulmonary artery hypertension. You said that when the child is born, the pulmonary vascular resistance is high, pulmonary artery pressure is high. That will result in
right to left shunt at the level of PFO or ASD, which is
because of because significant tricuspid regurgitation, they can have right to left shunt, and that will result in some degree of cyanosis. Then what happens?
And after as the child grows, the pulmonary pressure decreases. As a result, this right to left shunt decreases, and there is no more cyanosis.
Yeah, the pulmonary vascular resistance comes down, the TR becomes less, the right left shunt decreases, and it can even become left to right shunt, and the patient becomes symptom free. Okay, what else?
Sir, as the age advances and the disease progresses, the right ventricle, when fails, at that time again the right ventricular end diastolic pressure increases, TR increases. Again, there is a right to left shunt develops.
Very good. Very good. Subsequently, when the patient develops a RV failure or RV dysfunction, that can result in elevation of the right atrial pressure, and the right to left shunt gets re-established, and the patient can become cyanotic. So, that can happen. So, the features that is this patient is presenting with can be explained by Epstein's anomaly also. So, we will consider Epstein's anomaly as a strong possibility. Okay, right. So, what else? Is there any point which you think that is unlike is against Epstein's anomaly?
Yes,
One point which is maybe in favor of Epstein's anomaly is that none of the doctors who had seen her has suggested an intervention. So even those atrial septal defect, and treating doctors would have recommended that this is a treatable lesion, and also it would have been told to the parents that there is a defect or a hole in the heart and which can be closed. So no doctor advised her a closure of the hole in the heart. So that is a one point for us to suspect that Epstein's anomaly is a strong possibility. From the story part, both can be entertained, that we can differentiate only from the clinical examination, but the absence of advice by any of the doctors that she has got a defect which can be closed by a procedure is a point more in favor of Epstein's anomaly than an atrial septal defect. Any other differential diagnosis? Do you think that this can be just absent pulmonary valve with the PS and PR? Usually,
Yes,
this,
sir, that's
usually that is associated with tetralogy of Fallot, and from the story, it does not fit in with the tetralogy of Fallot. So the possibility is unlikely, but we will keep very low in the list. Okay. Any other condition would you?
Sir,
Yeah.
can it be acquired
Acquired?
sir, acquired heart disease like sir, endomyocardial fibrosis?
Well,
But
because the child is symptomatic from 6 months, that is the only thing.
sir,
Because it's symptomatic from 6 months, I would like to discuss the various congenital heart disease possibility. Because the child is detected to have a precordial activity and a heart lesion was detected by the examining doctor in the early childhood. So I think I would go more in favor of congenital heart disease than other conditions like Epstein's, RV and myocardial fibrosis. Any other differential diagnosis anybody would like to discuss in this patient because of the RV involvement? So we have discussed the atrial defect, we have discussed the Epstein's anomaly, we have discussed the partial anomalous pulmonary venous drainage, we have discussed the total anomalous pulmonary venous drainage.
Sir, can it be congenitally corrected TGA, sir?
Congenitally corrected TGA. TGA with left-sided Epstein's anomaly. How does congenitally corrected L transposition, what is the common lesion in a patient with L transposition?
so the left-sided might regurgitate lesion.
One there can have a left-sided valve can have an Epstein's anomaly. There can be left-sided regurgitation, which for all practical purposes, a left-sided AV valve regurgitation.
Sir, complete heart block.
They can have a complete heart block. What is the commonest defect associated with the L transposition?
Sir, VSD.
VSD, large VSD. They usually will be associated with the large VSD, and that is the usual presentation. Most of the patients will have large VSD. They can have Epstein's anomaly type of a left atrioventricular valve displacement, and these patients can have sometimes can have a AV block, complete heart block, and these are the usual problems. So natural history does not fit in completely with the development of symptoms at the age of 55, 60. Because they got a large VSD, they can develop symptoms early in life. So I would consider that as slightly low in the list. I will give still importance to the first two conditions that we have thought of. One is atrial septal defect, and other is Epstein's anomaly. I would consider atrial septal defect above Epstein's anomaly, because if you take the incidence of atrial septal defect, which is much more frequent than Epstein's anomaly, so I would like to consider that possibility first. Only point by means of which I may consider Epstein's anomaly above ASD is only if the doctor was correct in his diagnosis and he has not recommended a defect closure. If the defect closure was recommended, then and the patient did not undergo, that's a different question. Here there was no recommendation from the treating doctor that the child is having a defect, and the defect can be closed by a interventional procedure. So that is a point I would consider as against the diagnosis of atrial septal defect, and that will be, or rather keeping the diagnosis of Epstein's anomaly above atrial septal defect. Partial anomalous pulmonary venous drainage still lower in the list, and possible the total anomalous pulmonary venous drainage is unlikely. Any other condition that you would like the right side lesion, which can you do you think this can be a Garbody shunt where there can be shunt from left atrium to the right atrium? Sorry, left ventricle to the right atrium.
Sir, we cannot explain cyanosis.
Yes, we cannot explain cyanosis, and usually the shunt is not progressive. See here, the patient has got from the story that she has deteriorated over a period of time. There she developed atrial fibrillation. All those things are a bit odd for a LV2 RA shunt. So on the basis, I think we'll stick to the diagnosis of the two. Which one you think is more likely? Is it Epstein's anomaly or ASD? Manjunath, what is your opinion?
ASD, sir.
ASD, you would like to put ASD as the first one because of the it is the number of ASD cases are much more frequent. But only point is
Yes,
that
sir.
nobody has recommended an ASD closure. That is the only point which actually is slightly odd for ASD, because ASD now everybody knows it can, because she's 53. So in her childhood, the ASD closure definitely was possible, and she actually consulted doctors. Nobody had advised that she should undergo ASD closure. So that is the only point which I would think that maybe still I think that I would like to put ASD as the first possibility. Second, abstain surrender. Okay, now there is a small problem because I have 8 o'clock. I got a meeting. So that will be there for about 15 minutes. We have got two options. One, we can close the discussion here and restart it after 15 minutes, or we can postpone the rest of the discussion to next session. What do you want me to do?
So we will restart after 15 minutes.
Okay, right. Arti, are you there?
Yes, sir, I'm here.
See, we will break for 15 minutes, and then I will get back after 15 minutes, and then we will continue with the discussion.
Okay, no issues. I'm here.
Okay, right. So participants, we will discontinue for 15-20 minutes, and I will be back by about 15-20 minutes, and then we can continue with the discussion. Okay, yes.
Hello.
Hello, yes.
Hello. Hello.
Hello, yes.
Yes, madam. Hello, madam. Hello.
Hello, yes, ma'am.
Yeah, sir has come. Hello. Madam,
Hello, yes.
can you hear me?
Yes, yes, ma'am. You are perfectly audible.
Again, I have to share screen. There was some
Okay.
problem in Zoom. This one, it was I was logged out. Some problem with the Zoom
Okay.
connection.
Okay.
So I think I have to again share screen, na?
Yes,
Madam?
ma'am. Yes, yes, yes,
Yeah.
ma'am.
Then share screen. 1 minute. Again, I forgot. Share screen. How to go to this one,
Hello.
madam?
Ma'am. Hello,
How
yes.
to go again to
Share
this
screen.
share screen, but how to go my PowerPoint?
Okay. Okay, okay. मैम
I am
एडवांस का
unable to go
ऑप्शन
to
दिख
my
रहा है
PowerPoint.
मैम आपको एडवांस का ऑप्शन दिख रहा है
हैं? अभी वो दिख रहा है
Advance.
इंटरेक्टिव मीट बाय इमेज का। हाँ, अब आ गया है। रुकिए एक मिनट।
ओके ओके
हाँ मैडम, अब आ जाएगा। हाँ, आपको मेरा स्क्रीन नहीं दिख रहा है ना?
नहीं मैम अभी नहीं दिख रही
एक मिनट। जूम, सॉरी। हाँ, शेयर स्क्रीन। हाँ,
यस
अभी दिखा मैडम?
यस मैम योर स्क्रीन इज विजिबल
यू कैन सी ना?
yes yes ma'am ma'am can you do the slideshow mode
But I cannot see my slides.
but ma'am your slides is visible case presentation by Dr. Saroj right
है मैडम?
ma'am but your slides is visible okay ma'am you cannot
1 minute, ma'am. I am unable to join. Live. Launch. Hello.
hello yes ma'am
Yes, ma'am. I am unable to. How to Zoom? It is showing me you are screen sharing, but I cannot see.
ma'am you can you please reshare your screen
What to do?
ma'am can you please reshare your screen
You share. Okay.
yes
Okay. I did it. Now can you see?
yes ma'am your slides is visible
But okay. But I am unable to see the things.
sorry
How should I go?
sorry okay ma'am can you do the slideshow mode
Slideshow mode. How to go?
ma'am downward side पे
No, here it is showing launch meeting.
मैम हेलो मैम डाउनवर्ड साइड पे आपको जूम का ऑप्शन दिख रहा है उस पे क्लिक कीजिए
मैंने जूम का ऑप्शन में क्लिक किया।
हाँ उस पे क्लिक कीजिए अपना जूम की मीटिंग है ना वो ओपन कर दीजिए
ज्वाइन ए मीटिंग दिखा रहा है, साइन इन।
सॉरी
ज्वाइन ए मीटिंग, साइन इन।
नो नो मैम लॉन्च मीटिंग का ऑप्शन दिख रहा है ना आपको
हाँ, यहाँ
आपको लॉन्च मीटिंग का ऑप्शन दिख रहा है हेलो
तो या इंटरेक्टिव मीट बाय हेल्थ मेजिका दिखा रहा है। शेयर
सॉरी
शेयर स्क्रीन करूँ ना?
हाँ शेयर स्क्रीन कर दीजिए।
मल्टीपल विंडो क्यों दिखा रहा है? मैडम कैन यू सी माय दिस थिंग?
Yes ma'am, your slides is visible.
Okay, but I cannot see anyone of you. Can you see me? Now it is. I got it.
Yes,
madam.
yes ma'am, yes ma'am, you are perfectly visible.
I'm sorry, I am very bad in this.
Okay ma'am, can you do the slideshow mode?
Sir has come.
Ma'am, slideshow mode. Yes ma'am, yes, उस पे click कर
Okay,
दीजिए।
fine.
Yes ma'am, it's perfect.
हाँ. Sir has come, madam.
Ma'am, just 1 minute. No ma'am.
Okay. Madam, can you hear me?
Yes ma'am.
One thing, on my slide, I can see these participants list, so that my everything is little hidden. How to?
Yes.
Yeah, hidden. I want it to be clear. Yeah,
Okay, okay ma'am.
my screen is getting
Yes ma'am. Yes ma'am. Your screen is visible and
no, what I am telling on my screen,
yes.
because I can see the video.
Okay.
This is my screen is half obstructed with the this video. How should I clear it? I'm not doing it because it may go. That's it.
हेलो
Hello.
मैम, लेफ्ट अपर साइड पे 3 आइकन दिख रहे हैं क्या?
Yeah, three dots. Yeah.
यस यस
Huh. Should I do those three dots? Hello.
मैम, लेफ्ट। हेलो मैम, लेफ्ट आइकन पे क्लिक कीजिए ना एक बार।
ये three dots. Hello.
हेलो
Yes, madam.
मैम, आपका वीडियो जहाँ पे दिख रहा है ना
हाँ.
मैम, वहाँ पे लेफ्ट साइड पे 3 डॉट दिख रहे हैं आपको।
Right side with three dots. Right.
3 आइकन, सॉरी।
हाँ.
हाँ
4 icons. हाँ. Mute my audio, stop video, choose virtual background. That's it.
हेलो
Yeah, ma'am. Hi, I'm colleague of Arti. From आपको means problem ये है ना कि आपको सभी के videos दिख रही है, right?
वीडियो के
हाँ,
लिए नहीं, मेरा जो स्क्रीन है वो ढक जा रहा है।
right. Yes. जहाँ पे आपका वीडियो आ रहा है ना, उसके
हाँ,
ही
हाँ,
लेफ्ट टॉप साइड पे आपको 3 आइकन्स दिखेंगे in the sense of like minimize icon and like that.
राइट राइट।
हाँ, उसमें से लेफ्ट वाला जो आइकन है ना, लेफ्ट वाला मिनिमाइज का आइकन होता है,
हाँ हाँ हाँ
हाँ वो क्लिक करेंगे तो छोटा सा आपका नाम जस्ट आएगा वहां पे।
राइट, हाँ टेकिंग दिखा रहा है, राइट।
तो वहां से आप उसको ड्रैग करके दूसरी जगह पे रख सकते हैं अगर वो आपको मतलब अभी भी बीच में आ रहा है तो।
अब नहीं आ रहा है, उसको करने से
हाँ,
नहीं आ रहा, बट
ओके,
वो चला गया है, वो वीडियो चला गया है, राइट।
चला, हाँ आपका मतलब ऑल्दो हम आपको देख सकते हैं
I
बट।
now understood. Now I understood.
ओके,
Understood. Got
थैंक
your
यू,
point. Yeah, thank
थैंक
you
यू।
so much. Say what I am so, I don't know how this Hello, ma'am. Hello. Hello.
Hello.
Oh, sir has not come, no?
Let me check. Not yet, ma'am. Sorry. Not yet.
No, I thought whether I am missing or not. No, it's okay.
Yeah.
Okay.
Yeah.
Okay, I got slightly delayed. Are you there, Saroj?
Yes, sir.
Okay, so shall we go to the presentation now?
Yes, sir.
General physical examination. So we have discussed the case, and we thought two strong possibilities that we are entertaining are: one is atrial septal defect, and another is Epstein's anomaly. And slightly lower in the list, we are also considering a possibility of partial anomalous pulmonary venous drainage, and total anomalous pulmonary venous drainage we thought is very unlikely. Okay, so we'll go to the physical findings, and then we'll try to find out whether we can come to a proper diagnosis. Okay, right? Yes.
Yes, sir. So general physical examination.
Yes.
Patient dyspneic, respiration rate 28 per minute, BMI 17, no dysmorphic features, hairline is normal, pallor absent, the cyanosis SpO2 85% in all four limbs. There is no differential cyanosis. Mild bilateral pedal edema is seen, and clubbing is absent.
Okay. So from this, the initial physical finding, of the two conditions, which you think is more likely? We'll ask Manjunath, would you like to comment?
Sorry, sir. I just joined in, sir. I couldn't hear.
Now, you see, she has presented the initial general physical examination findings. We have discussed, we have considered two possibilities as strong possibilities for the diagnosis. One is heteroseptal defect, another is Epstein's anomaly. So, of these two, which one you think is more likely, looking at the physical findings or the initial general physical examination findings? Do you think that it could be heteroseptal defect, or do you think that it could be Epstein's anomaly? Or do you think that both are still should be considered equally important, and we need further data to come to any reasonable conclusion?
BMI is alarming, sir. BMI is alarming.
Yeah. She's a very thin person. Probably she has developed heart failure and must have been losing weight. What about she has got oxygen desaturation involving all four limbs?
Yes, all four limbs, sir.
So, do you think that this may give you some clue? Do you think that this could be more in favor of ASD or more in favor of Epstein's anomaly? Or do you think that both can be still considered as a before we would like to have other physical findings? I think let's go to other physical findings. I also fully agree with you that it may be too early, but a cyanosis of 85%, well, I would think that that may go in favor of both. Either in both conditions you can get cyanosis, so I think it will be too early for us to draw any conclusion. Let's go further. Saroj, let us go ahead.
JVP. Sir, 5 centimeter above the sternal angle in 45 degrees centigrade with absent A wave, prominent V wave. Sir, I could not understand very well whether it is a V wave or a C wave, sir. The timing was systolic.
So would you like to make it a CV wave?
I could not understand whether it was V or
say if you think that the wave is starting in the along with the carotid pulsation.
Yes, it was along with carotid, sir.
And that is persisting beyond the carotid pulsation, then you can say that it is a CV wave. Yes, in patients with tricuspid regurgitation, you can get a CV wave. See, if you look at the jugular venous pressure, the A wave precedes the carotid pulse, C wave normally occurs with the carotid pulse, and V wave occurs after the carotid pulse. So when there is a tricuspid regurgitation, the C wave can merge with the V wave. You can get a CV wave. You can describe that way. If the examiner asks you, why are you saying it is a CV wave? You can say that the wave starts with the carotid pulse, indicating that in timing it corresponds to C wave, and it extends beyond the carotid pulse, indicating that it is merging with the V wave. So it is a CV wave. That's fine. Okay, yes.
Pulse 70 per minute, irregular, low volume, bilateral symmetrical, no radial or radiofemoral delay, condition of the arterial wall normal, the blood pressure 100 by 60 in both upper limb and 110 by 70 in both lower limb. Apex pulse deficit 8 per minute.
Okay. Anybody would like to comment about JVP? Absent A wave, prominent B wave, normal Y descent. Any comments? She said that she has got the patient has got a CV. The wave starts with the carotid pulse, indicating that it is timing with the C wave and also extending up to the V wave. So does that give you any clue that the patient has got severe tricuspid regurgitation? Do you think that this is more likely in ASD or more likely in Epstein's anomaly? Monica, would you like to give a comment?
Yes, good evening, sir.
Yeah, good evening.
I think these findings probably go more in favor of Epstein's to me as of now.
Oh, why do you say that?
Because JVP, usually in Epstein's, JVP is not raised until and unless RV has failed.
Yes.
Going by the history of the patient, at the age of 53 years, she has developed tardive cyanosis. So
Okay.
I guess, and with this JVP, severe tricuspid regurgitation is present.
Yes.
So I would like to go more at present now with the Epstein's.
Okay. In general, you said that Epstein's anomaly, even though there is tricuspid regurgitation, the prominent V waves are unlikely. What is the reason?
Because the RA is very huge, sir.
Yes, very good. Usually RA is very huge, very compliant,
And it's
and
very
the tricuspid regurgitation, even if it is present, well, it may not give rise to very prominent V wave. But then what is the difference here?
now patient has developed RV failure.
Yeah, very good.
So that is giving rise to prominent V wave.
Prominent, very good. Do you like to give any comment about the JVP description of given here? Anything else you would like to add on to this?
Atrial fibrillation is it?
Yeah, that is very good. A waves are not. How do you differentiate between A wave and V wave?
With the timings, sir.
Yeah.
When the wave which occurs before the carotid pulsation, it's A wave.
Okay.
Which occurs after the carotid pulsation, it's V wave.
Very good.
And when the V wave is corresponding to the carotid pulsations, it is called CV wave.
Very good. And is there any other character which will help you to differentiate between A wave and V wave?
A wave is flickering, whereas the V wave is slightly sustained.
The A wave is sharp rise, sharp fall, because it is an active phenomenon. V wave is slow rise and a sharp fall. The rise is very slow because it is a passive phenomenon, and fall is rapid because of the normally functioning right ventricle sucks the blood from the right atrium. That will give rise to the Y descent, which is the terminal part of the V wave, or rather immediately after the V wave. So you find a slow rise and a sharp fall in V wave, while a sharp rise and a sharp fall in an A wave. So I also agree with you that looking at the findings, we have to think more in favor of Epstein's anomaly rather than atrial septal defect. But I will still keep my mind open, because we would like to have more evidence to come to any proper conclusion. Okay, go ahead. When you are trying to differentiate between the Epstein's anomaly and ASD, what will be the most important point that will definitely help you that this is ASD and not Epstein's anomaly on palpation? Manjunath, would you like to give a comment? What will be one single finding which will definitely tell you on palpation or the precordial?
Precordial bulge, sir.
The precordial RV pulsation, RV body pulsations. If you are getting RV body pulsations, it will be a strong point in favor of ASD. An absence of RV body pulsations, but you are getting RV outflow pulsations only, that will be strongly in favor of Epstein's anomaly. Okay, let us hear the findings of.
What about parasternal heave, sir?
Now that is parasternal heave.
Parasternal heave will not be present in Epstein's anomaly.
Yes. Where do you feel the parasternal heave in parasternal pulsations in Epstein's anomaly? Where do you find parasternal pulsations in atrial septal defect?
In ASD, we'll get in third and fourth left external border, sir.
Third, fourth, and fifth. You can say fourth and fifth intercostal spaces, you get the RV body pulsations, and you get the RV outflow pulsations in the left third intercostal space. So in a patient with ASD, there will be RV body as well as outflow, both are dilated, and so you can get pulsations in the fifth intercostal, fourth intercostal space, and third intercostal space. So in a patient with Epstein's anomaly, where do you get the pulsations?
In third intercostal space.
In the third intercostal space, because the body of the RV is becoming atrialized portion of the right ventricle, and the only portion which is functioning is the RV outflow, and that will give rise to RV outflow dilatation, and RV outflow pulsations can be felt. Very good, Saroj. Okay, right. Go ahead.
Inspection and palpation together. Chest, mild bulge seen over the precordium on the right side of the sternum. Some rippling movement is also seen in the left third intercostal space. Apex is fixed intercostal space outside the mid-clavicular line. Sir, I was a little hesitant whether it was LV type of apex or RV type of apex. Sir, but most probably, sir, it was localized and it was LV type of apex with medial retraction.
Now, how do you differentiate between LV type of apex and RV type of apex?
Sir, LV type is localized and there is a medial retraction.
But it is usually the apical impulse is felt in a localized area, and it is medial retraction will tell you that it is more likely to be LV type. And RV type?
Sir, in RV type, sir, it will be, sir, diffuse type, and there will be a lateral retraction. And sir, if we are getting the parasternal heave also together with, then sir, it will be continuous.
Yeah, very good. If you try to track the impulse from the apex towards the parasternal region, if you are getting a continuous cardiac pulsations are felt, and you are getting pulsations in the parasternal region which are actually more prominent than the apical impulse, then you can be certain that this is an RV pulsations, and RV is forming the apex beat. If it is both RV and LV,
so then, sir, it will be continuous, but it will be, sir, localized.
Yeah, what you will get is that a localized impulse is felt in the apical region, and as you track medially, there will be an area where the impulse becomes less prominent, and as you reach the parasternal region, the impulse will be again felt prominently. So you will get two separate impulses with an area where the impulse is very less prominent or not felt at all. The one which is the LV impulse, and other is RV impulse. So by doing this method, you can always differentiate between the LV, RV, and LV plus RV. In LV, it will be localized and there is no parasternal lift. 2, in RV, it will be diffuse, palpable at the apex, and it is continuous with the parasternal pulsations, and that will be purely RV. And when it is LV plus RV, the impulse is felt at the apex, which is more localized. And as you track medially, there will be an area where the impulse becomes less prominent or not felt at all. And then as you approach the parasternal region, the impulse can be again felt. So then that will make you think that this could be an RV plus LV plus RV impulse. So here, Saroj got it as a localized LV type. And when it is localized LV type, Manjunath, would you like to, up to this level, would you like to review your diagnosis? Do you think that this could be ASD, or still it could be ASD with Epstein's anomaly, or do you think we must consider something else as the differential diagnosis?
Any Lutenbach syndrome, sir? Because of LV type of attraction with the 6th intercostal space.
Lutenbacher syndrome, you will not get an LV type of an apex, because Lutenbacher, the left ventricle is
sorry.
Very small, and usually it will be huge RV, and usually they become symptomatic before this age because of the torrential flow. Do you think that you have to consider single atrium, where but still the LV impulse, well, Epstein's anomaly, sometimes you can get a LV impulse. The only impulse that you may feel is an LV type of LV impulse, and there may not be any parasternal pulsation. So of the two that we have considered, if it is an LV type, I think we have to change our priority. The first one may be Epstein's anomaly, and the second one could be an atrial septal defect. Okay, let us hear further. Saroj, let us hear further.
Systolic impulse is palpable at the left third intercostal space. Sir, the faint left parasternal heave, grade 2 only, sir.
Grade 2 parasternal heave. Oh, see, that will.
Sir, I think it was less than this only. Sir, very faint. Sir, one pulsation I could like Sir, I think this finding little confusing. Sir, 2-3 findings I was confusing. One JVT and this sir affect. And sir, this parasternal is maybe sir same pulsation. So which I am getting on the third intercostal space.
Now, what you should do is that, see, whenever you are looking for a RV body pulsation, you should specifically put your finger only in the fifth intercostal space. Because if the patient is having an RV outro pulsation, something like a tethering effect, you may feel pulsations in the fourth intercostal space, and that may make you that may confuse you. So, in a patient with Epstein's anomaly and also in RV endomyocardial fibrosis, you will not get pulsations in the fifth intercostal space. You will get pulsation only in the third intercostal space.
Sir, I was not getting it.
Okay, so you are not getting in a patient with ASD. What is the type of parasternal lift that you expect?
Sir, it will be, sir, because of the volume overload. Sir, it will be not sustained. Sir, forceful is sustained.
Yeah, they will get a very wide area of impulse because it's a volume overload. And if the patient has started developing pulmonary arterial hypertension, then you can get the volume overload plus some degree of sustained activity also can be felt. But in a patient with ASD, you expect very prominent parasternal pulsations. So absence of, or rather doubtful parasternal pulsations of grade 1 only, I think I would immediately put the Epstein's anomaly as the first possibility and ASD as the second possibility. Okay, right. Yes. Epigastric pulsations are present. Go ahead.
Or sometimes, sir, even in presence of severe TR in patients with Epstein's anomaly, you may have some thrill or TR means palpable TR, which may be missed as parasternal. That is what I feel in this case.
No,
if
you cannot get
anything.
In Epstein's anomaly, parasternal, tricuspid regurgitation murmurs are not very prominent because it's a gross there is a displacement of the tricuspid valve, gross tricuspid regurgitation, and unlikely that there will be any prominent tricuspid regurgitation murmur. The murmur will be usually very faint, and early systolic murmur and very loud murmur is very unlikely. Many of these patients with Epstein's anomaly can have a mid-diastolic rumble, which may be more prominent because of the one tricuspid regurgitation giving rise to an initial large volume of blood flowing from the RA to RV. And second, some of these patients with Epstein's anomaly can have some degree of stenosis of the tricuspid valve.
Stenosis of the tricuspid valve.
So they can have a mid-diastolic rumble, which sometimes becomes very prominent. But systolic murmur, which is very prominent, is very often not audible. Very often you may not hear a systolic murmur at all. You diagnose tricuspid regurgitation by looking at the jugular vein pressure. It will be very faint murmur. That would be the usual finding in Epstein's anomaly. But if Epstein's anomaly is suspected, you can hear a mid-diastolic rumble, no parasternal lift, especially in the fourth and fifth intercostal space, and you can get the splitting of the first heart sound. Multiple sounds. First heart sound is split. You can sometimes hear a third heart sound. You can hear a split second heart sound. So multiple sounds are audible in the parasternal region. That's the one which makes you suspect that it could be an Epstein's anomaly.
Yes.
Okay, right. So Epstein, the epigastric pulsation, I think that makes us a bit more confusing because Epstein's epigastric pulsation, I would. All probability is very unlikely in Epstein's anomaly because that purely indicates that the RV body is dilated and epigastric pulsations are quite unlikely in Epstein's anomaly. So I will now I will keep my mind still open because Epstein's anomaly.
I was thinking, sir, actually this was because she was so thin now, so that's why I could just see the epigastric pulsation.
But even then, the presence of epigastric pulsation usually indicates that in all probability, indeed indicates the RV body pulsations. And in this case, if you're strongly feeling the epigastric pulsations, I will consider it as a point against the diagnosis of Epstein's anomaly. We'll keep the mind open because there are a few, because in a patient who does not have a left parasternal impulse, and if you want to get epigastric pulsation, then what is the situation where you can get epigastric pulsations, but you are not getting the left parasternal impulse? Saroj?
So it is for aortic pulsation.
No. You are saying epigastric pulsation is present. You are implying that this is an RV pulsation. It's not. So, or not epigastric aortic pulsations. Are you considering that this is an aortic pulsation and not RV pulsation?
So I think it was not RV pulsation. It was aortic pulsation. Sir.
How do you make out between RV
So
pulsation?
by 3-finger test, sir, we can see if it is coming from the up and if it is it moves